Hello, it's Dr. Garrett Pohlman, host of the Prostate Health Podcast. We are here today at the 30th Annual International Prostate Cancer Update. Today we'll be talking about active surveillance for low-risk prostate cancer. So stay tuned for more information. So the big question is this: how can men and those who care for them better educate themselves regarding prostate health, the conditions that affect the prostate, and the latest technology in managing these conditions? That is the question, and this podcast will provide the answers. On a weekly basis, we will be chatting with experts, innovators, and leaders in the field of urology, sharing useful information with the general public to improve their lives and increase their overall health. My name is Dr. Garrett Pohlman, and welcome to the Prostate Health Podcast. Prostate Health Podcast is for informational purposes only. Nothing in this podcast should be construed as medical advice. By listening to the podcast, no physician-patient relationship has been formed. For more information and counseling, you must contact your personal physician or urologist with questions about your unique situation. We are excited to have renowned prostate cancer expert Dr. Lawrence Klotz join us today on the Prostate Health Podcast. He currently serves as Professor of Surgery at the University of Toronto, holds the Sunnybrook Chair of Prostate Cancer Research, and is the chairman of the World Uro-Oncology Federation. Dr. Klotz was a founding editor-in-chief of both the Canadian Journal of Urology and the Canadian Urology Association Journal. He was a founder and is chairman of the Canadian Urology Research Consortium. He was awarded the Order of Canada for his work in prostate cancer. Dr. Klotz completed his fellowship at the Memorial Sloan Kettering Cancer Center in New York in urologic oncology. Dr. Klotz is a widely published urologic oncologist with over 350 publications and 6 books. Dr. Klotz, welcome to the Prostate Health Podcast.
Thank you.
Dr. Klotz, the diagnosis of prostate cancer can be very distressing. For a lot of individuals, the first instinct is to want to jump right to aggressive therapy such as surgery or radiation. Now, some men are candidates for active surveillance, which has increasingly emerged as a viable option for men who decide not to undergo immediate radical treatment for prostate cancer. So can you tell our listeners, first of all, what is active surveillance?
Thanks, Garrett. So I would say just a few key points which are the basis for this conservative approach. And I think the first thing to understand is that low-grade prostate cancer, which is what we're talking about, is not really a cancer the way people think of a disease when they hear that word. Low-grade prostate cancer develops normally with age in men. And in fact, a man's likelihood of having this in his prostate is roughly equal to his age as a percentage. So, for example, about 2/3 of men over the age of 65 will have small amounts of low-grade prostate cancer. And we know from a great deal of clinical experience and a lot of genetic studies that this low-grade prostate cancer has a 0 chance of metastasizing. It never, ever spreads. And that is very powerful information because it means you don't have to worry about missing the boat on low-grade prostate cancer. This has several other terms now. It's either called grade group 1 or Gleason 6. They all basically refer to the same thing. So the issue with this grade group 1 prostate cancer or low-grade prostate cancer is that it's a marker for the patient being an increased risk for having a more serious cancer that was missed at the time of the biopsy. So the major approach of active surveillance, it's not no treatment, and it's not just sending the patient away. It's closely following the patient, in most cases, to find that higher grade cancer that some of these patients have that we don't know about. But the grade group 1 cancer, the Gleason 6 cancer that we know they have, is no threat to their health whatsoever and doesn't require treatment. So that really is the basis for this concept of active surveillance or initial conservative management.
So what would you say, I think you touched on it a little bit, but what are some of the advantages of doing active surveillance over treatment?
Yeah, well, the real crux of the problem is that treatment for prostate cancer, it's not like having an appendectomy where you undergo a procedure, you recover, and you're back to normal. If that were the case, it would be another story. But the difficulty is that the treatments for prostate cancer, in most cases, have the potential for lifelong consequences on quality of life and affects things like erectile function, voiding dysfunction, incontinence, rectal problems with radiation. So for a patient to be exposed to those side effects if they've got a serious life-threatening disease, that's the kind of trade-off that happens all the time in medicine. I think most people think it's reasonable. If your life is saved and you end up with some erectile function, for most people, that's an okay trade-off. But to undergo that kind of treatment for something that does not pose a threat to your life, that's a different story. And I think that is why there's been so much interest and acceptance of this concept of conservative management or active surveillance.
Dr. Klotz, you've definitely given our listeners some very valuable information so far regarding active surveillance. We're going to go ahead and take a quick break, then we'll be right back to discuss what a man may expect when going on an active surveillance protocol. Thanks again for joining us today on the Prostate Health Podcast. If you're enjoying the show today, make sure you visit my podcast website at www.prostatehealthpodcast.com. There you can find show notes to all our episodes. You can also click on our resources tab, where you can find links to our trusted partners of the podcast, as well as links to books, resources, and products, all of which can help in your journey with either an enlarged prostate or prostate cancer. You can also sign up to receive my free What to Expect guide, which includes checklists of what you need to bring and how to prepare, including what to expect with 3 different scenarios, including your initial urology clinic appointment, a prostate biopsy, or prostate cancer consultation. Sign up for the free guide on the homepage of www.prostatehealthpodcast.com or access this guide directly at www.prostatehealthpodcast.com/clinic. So are there any additional, tests to look at in terms of counseling patients in determining, those in that low risk group who would be candidates for active surveillance?
Yeah, so the field is changing very rapidly, and there is a whole slew of new molecular tests and imaging tests that allow us to do even better with this approach that we have in the past. And I should say that the experience now that's accumulated around the world is more than 15,000 patients followed prospectively in this way, and the likelihood of patients dying at 15 years is somewhere around 1 in 100. And we think going forward that may be even lower because we're getting better at it. And the first game changer was called multiparametric MRI. For the first time, we were actually able to image prostate cancer to see it. It was very unique disease until then because unlike just about every other solid cancer, which is diagnosed with an image, we weren't able to do that for prostate cancer. We only diagnosed with a biopsy. So now we can see it in most cases. That is a huge step forward. It's not perfect, but that has really enabled us to find the bad actors much earlier. And the second huge area is the area of molecular biomarkers. There's at least about 10 biomarkers now on the market, some of them based on urine assay or serum assay or tissue assay after a biopsy, all of which have the ability to identify the patient who's got that higher risk cancer that we're more concerned about. So the field is changing for the better, and I think going forward, the results of active surveillance are going to be even better than they have been in the past.
So is there a set protocol, or is this kind of vary from urologist to urologist in terms of how we follow these patients in terms of PSA, prostate exam, and even repeat biopsy?
So there's some basic principles, and how they are applied does vary to a degree around the world, but there's a basic consensus that patients should have a PSA about every 6 months. They should have at least one confirmatory biopsy done after the initial biopsy, and increasingly we rely on MRI. So we do an MRI after the initial diagnosis of grade group 1 cancer, and then approximately every 3 years, more often if there's some trigger like a rapid rising PSA. We do not treat the patients just because their PSA has gone up. We did do that for quite a while, and that turns out not to be a good strategy. That's another way that the whole approach is improved. And there is quite a lot of variation in terms of how often the biopsy is repeated. So by and large, men don't like the biopsy, and there are some relatively rare but potentially serious side effects. So we're trying to move away from the biopsy by relying more on MRI and potentially on molecular biomarkers. We still do it around every 5 years, depending on the patient's age and what the other parameters are doing. And the other thing I should just add is there's kind of a transition once the patient reaches an age where they no longer benefit from early detection of high-grade prostate cancer, and that's usually around age 80. We switch to what's called watchful waiting, meaning no more biopsies, no more imaging. We just follow the PSA, and if the patient looks like something is happening, we then reevaluate them. But there's increasingly, as these populations of patients managed this way have been getting older, we're doing that switch more and more frequently.
So certainly this concept of active surveillance is not a new idea then.
Well, it was a new idea for us when we started it, which was approximately 22 years ago. Up till that time, you basically had two options. Either have radical treatment with its attendant side effects, or no treatment until the patient came back with back pain due to bone metastasis in his vertebra. And, this goes back a ways, but at the time that just didn't seem to make much sense. So that's why we sort of came up with this strategy of, monitoring the patient over time. And I guess the key insight is that time is a very powerful tool because the serious diseases progress over time. And if you have a disease that can still be treated curatively later, then you have the opportunity to avoid treatment for the majority. And that concept, which underlies active surveillance, has now been adopted by at least 4 other cancer sites like thyroid and breast, ductal carcinoma in situ, and kidney cancer, and some others. So that's been one of the most gratifying things about this whole thing, is seeing how the concept has been influential in other fields.
Well, perfect. Well, so in summary, active surveillance, again, can be a valuable tool or option for some men with low-risk prostate cancer, and really allowing them to avoid some of the side effects of treatment.
Yeah, I certainly agree with that 100%. And just to support what you said, the guidelines now pretty much all over the world advocate active surveillance for this grade group 1 or low-risk prostate cancer. So there's a real, I would say, international consensus at this point.
Well, Dr. Klotz, we really appreciate you taking time out of your busy schedule today to visit with us today on the Prostate Health Podcast. This should be a very valuable listen for our viewers to really help empower them in gaining more information. Thank you again.
Absolute pleasure. Thanks for the opportunity.
Thank you again for listening to the Prostate Health Podcast. Follow me on Twitter and Instagram at gpohlmanmd. Don't forget to join us next week for another episode.